here, so if y'all want to just make your way on up here, that would be great. But so Commissioner Toomey will be coming, and Deputy Director Mary Havoc and Deputy Director Hempling. Am I saying it kind of right? Close? Perfect. Am I close? Good. Yeah. Good. So we have not heard what brought you to where you are today, and that was what our earlier presenters spoke about too as they first started. So I want to start with that if we can, and I'm going to tell you without a doubt it's selfish. Your stories are very interesting, but they have revealed very much so far, I think, as to how important your work is and how deep it is in your heart. That this is not a job, it is work for good reasons. So if y'all would make sure before we get started, I think there's a couple of microphones on each table, the three of you to kind of introduce yourself and tell us a little bit about your path to today. And then we'll start with something else. Y'all do that first.
Well, good morning, or good afternoon. Sorry, that really is a perfect description of how my day's gone so far today. My name is Chris Hempling. I'm the Deputy Division Director and General Counsel for the Division of Family and Children's Services. Prior to, I just celebrated my 1-year anniversary as the General Counsel and Deputy Director for DFACS. Prior to that, I served as a Special Assistant Attorney General representing the agency in our abuse and neglect actions out in Newton and Rockdale County. I was a SAG for 7 years in that position. This is really kind of a pseudo second career for me, because prior to going to law school, I worked for various colleges and universities for about 7 more years, organizing community engagement and student engagement activities at the collegiate level, up in Illinois for a couple years, and then back in Westerville, Ohio. Actually, if anybody watched the Democrat debate last night, that was at Otterbein University, which is where I served as their assistant director for student civic engagement for 4 more years. I had always wanted to go to law school. I went to law school, thought I wanted to go into creditors' rights. Did that for about 6 months and hated every single minute of it, largely because I didn't feel like I was actually working towards a cause or working towards a mission. This work provides me that outlet. The agency has just over 13,000 children in our temporary or permanent custody at this time, and every single day the work that we do at DFACS helps those children and those families, protects those children or helps strengthen those families. That way we can either find permanency for those children or get those children home into a safe home with loving, caring caregivers that are going to offer them the best life possible. So that's a little bit about me.
Hi, good afternoon. My name is Mary Havoc, and I'm the Deputy Division Director for Child Welfare at DFACS. And I found my way here through a random internship my senior year at the University of Georgia. I was placed at the Division of Family and Children's Services, which I wasn't thrilled about, but I was sure was going to be excellent experience for my resume for me to use elsewhere. That morphed into my first job, and 22 years later I am here, and I wouldn't want to be anyplace else. I believe that public child welfare is the best way for us to make a difference in the world, because children living with families who are strong makes the community, it makes our state stronger. So that is my why. I've had the opportunity. Well, let me say this. I'm new to my current position. I started at June 1st, but I have had a variety of roles with the division, from case manager to leading our field operations. So I've had lots of opportunities along the way. I'm thrilled to be here and get to meet some folks whose names I have heard since I started my new role at the state office in collaborating, because there's a lot of collaborating that we do at a state level and of course happens at the local level as well. On a personal note related to this topic, I'll say that I will always be grateful for my children's pre-K experience, because my oldest failed his vision screening after passing it at the pediatrician's office. Pediatrician said, you don't have anything to worry about. He was doing okay academically for his age. He failed the screening. And so they said, well, we're sorry, but you're going to have to go get some follow-up. So we did, and it turned out he had a vision problem. So that was detected through his pre-K program. So for that, I'm grateful. Yeah.
Thank you. I was hoping you were going to say he was detected in a public health clinic. And I was I'd like to say that's what we do.
Well, we do go there for flu shots.
Good. Now, I want to introduce myself. I'm relatively new to this position, so I haven't met all of you, and just appreciate your commitment to our work. My name is Kathleen Toomey. I was appointed Commissioner of Public Health in the last 3 weeks of session, so so you didn't see much of me this past session. I started my career, I actually always wanted to be a doctor in Africa, like Albert Schweitzer. That's what I thought I was going to do in medical school. I was a National Health Service Corps scholar, had a fellowship, so I had to pay back some time to the government. And I ended up paying back my time in Northwest Alaska, north of the Arctic Circle, but as far from Africa as you can get. But it was in that work in an Inuit community that I really developed my passion for public health and the recognition that taking care of one patient at a time is not going to have the same impact. It's actually working at the community level to try to change the culture of health. And so I kind of made a circuitous route through San Francisco, where I worked on HIV, early cases of HIV in the early 80s at San Francisco General Hospital, and actually ended up at CDC. And was there for a number of years before I found my way to the state, initially as a state epidemiologist. That's the one that reports the Legionella and vaping disease now and other things. And eventually as the director of public health when we were under the Department of Human Resources. And I served in that role under 3 governors until about 2005, when I ended up going back to CDC again to a number of opportunities, including running CDC's operations in Botswana. So I finally made it to Africa. But perhaps most significant to what I'm doing now, the 3 years, about 3.5 years ago, I was asked by Dr. Fitzgerald to come to Fulton County and take over Fulton County Health Department at a time that you all had been working on a piece of legislation that was going to allow Fulton County to transition to be like other boards of health under the state's auspices. And so I'm very proud to say that we led that transition, and now the Fulton County Health Department is the Fulton Board of Health. And that was a very important work that I did at the local level, but it also showed me a different kind of public health that we do at the state. I resigned from that position at the end of December because I felt that we had done that transition, and was delighted when I got a call from the governor's office and asked me to just come over and talk about health. And so I'm here today, having been offered the position of commissioner, which I'm thrilled to be here. I come into this job not for the second time with a new set of eyes, because I'm coming into it having worked at the local level and recognized the importance of local public health to what we do, and how our role, the state office, and you can see my staff here are nodding their heads because they've heard me say this so many times, our role of the state office is to support in every way local public health, to do the job at the community level. So that's a long and convoluted path that got me here, but I think it was important to give you that perspective because my commitment to maternal and child health goes way back to northern Alaska, so it has been carried with me ever since.
Well, thank you to each of you for being here. So, I'm going to ask first, before we get started, if there's anyone that has any kind of comment or anything you want to add to us. I have a few questions, and I'm sure that this great group here is loaded with all kinds of questions too as well. But is there any desire that you'd like to share with us right now about this focus that we have picked up of 0 to 3 and how valuable it is to successful lives as well as being a great child?
I still have my mic, I can just say very quickly, and we had a chance to talk a little bit during the break. This is such a critical time to give children the tools they need to grow healthy, whether it's to be able to learn physically and mentally. And this is the reason I like home visitation, and we will get you that business case, and I promise you, we've already started working on it. Is that it actually addresses two issues. It addresses not only the health of the baby, but also the health of the mother, which can affect the infant outcomes. And I hope that we can expand our work in parents as teachers and home visitation from 20 counties to statewide, where this is occurring. And I was just in Valdosta a few days ago, where the staff doing the home visitations were saying how valuable the mothers were finding this to be, and how they were identifying conditions in the children that would have been unrecognized otherwise, and giving supports to the family around social needs and health and nutrition and other things that they would not have gotten otherwise. And you can't necessarily expect a mom to be able to get transport, particularly outside of metro area where there's not easy access to transportation services, and providers are far apart. So I hope we'll be able to convince you with a good business model as a businessman that this is an investment worth doing.
Barry and I were preparing for this yesterday, and in our conversation to prepare for this, often we don't have intentional conversations about this age group, about how to truly prevent further harm, further trauma. This age group from, in our case, coming into foster care sometimes. So much, at least of what the division does on a regular basis, is react. React to reports of abuse or neglect, react to constituent reports, react to federal laws, state laws, new regulations. But we know, as Dr. Toomey was saying, reacting is expensive. Think about reacting to an employee that you lose to need to then rehire a new employee. Hiring employees is substantially more costly than retaining employees. We know that. It's the exact same thing with foster care or family preservation services. Family preservation services, we know if we do those services right and we are intentional about our work to prevent removals, that ultimately is much more cost effective for our families and those children. But in addition to the cost of it, the trauma associated with a removal long-term is far more costly because we know that trauma does not get fixed overnight. That trauma takes years and years and years of concerted efforts and services in order to try and even get that child back to a kind of a normal state of being. So being able to have this conversation today and think intentionally about how we can react less and prepare and prevent more will be far more beneficial for our families and the youth in the state, and also far more beneficial for the state taxpayers when we think about holistically how to help this population as a whole. Chairwoman, I think it's you.
Anyone else? Any other comments here? Okay. Okay, well, I'll start a little something to spark the conversation and then I'll get ready to jump in. Okay. What would an ideal system of care for young children and their families look like? It's that dream big moment. That ideal, perfect. Everything is good.
I can try to start us off here because we're asking ourselves the same question about, you know, as we the partners start to wind down the current plan and look to the next plan. I would say the system, payer is such a big driver of how much you are able to access, what access points look like, and so on and so forth. And the coordination piece is so key. I'd like to echo the comment about being intentional, because sometimes once you sit down long enough on a regular basis to connect the dots, having regular opportunities, and having sustaining participation. We're also busy and we go in so many different ways, but having opportunities to come together on a regular basis to start and see plans through to implementation. But that payer piece is just, it's really key to starting programs, sustaining programs. Oftentimes there are grant dollars that are available for programs. It could be state grant dollars, could be federal grant dollars, and you scale up. And then if you're unable to implement that sustainability plan, oftentimes those hard-fought efforts sometimes go away. And so speaking specifically about APEX, that's been one of the key drivers for that program is finding that model and nudging our providers towards sustainability by tapping into those payer sources. So earlier I mentioned one of the ways we work is by investing in infrastructure, but I didn't come back to that, and so that's what I meant by that. The best practices for that particular program says that if a provider is able to reach a productivity level of 60%, then that position becomes self-sustaining. But there are other services that are non-billable that are so important, like classroom observation and those sorts of things. And so long-term, as funding shifts, the department is aware that we would need to be thinking about those non-billable services. But if we're able to shift those productivity costs over time, then at least that position can be self-sustaining, so you're not carrying so much of that staff time.
So the financial resources, absolutely. I think in addition to that, I see a couple of different areas when we think about a perfect system. Knowledge of the current resources that are out there. It's very rare for me to anymore go into a meeting and not learn about an already available resource or program and making sure that all of our agencies, or any agency that is dealing with this constituency, has an awareness of the current programs that are out there. I think one of the challenges that we run into all the time is, well, let's create a new program or let's create a new initiative, when sometimes or often we may already have a program, or one of our agencies may have a program that's already dealing with this constituency or with the identified problem that's there. So a knowledge and education of the current resources. One of the other challenges, I think everybody sees this because we all have competing interests, and that are always pulling our attention away, is the implementation of those programs. When we have great ideas, those great ideas are then placed upon our finite set of resources. When you look at DFACs, on our OFI side of the house right now, we have the fewest number of OFI welfare employees that I think we've had since 2005. As we continue to think about new programs on our Office of Family Independence, and how they could best utilize or implement those programs, being cognizant that the implementation needs to, again, we're using the word intentional a lot, but not be lost with the 90 other competing interests that our employees are doing on a regular basis. And then I think lastly, it's making sure that the resources, whether those are services, programs, funding, are also placed with the identified need. Very often, we don't know exactly what or where the needs are, and we'll come up with a different program, but then that need, or that program may not actually fit the need that's out there. So making sure that we have a good avenue process to identify those needs, and then to help create the solutions for those needs.
I would add to that we heard about some really good programs today, like home visiting, for example, but we also saw a pretty short list of counties that program is available. So expanding some of the programs that are already existing to be more statewide, and that any of us, I think if a parent of a child this age came into contact with any of our agencies, that we could appropriately refer them at any place in the state to the right place to get services, so that we don't, collaboration of course is important, and locally we need to continue to work on that, but build at the same time so that we expand those.
And I would say I agree with everything that's been said. I think my vantage point is from public health, where I see the importance of the social and emotional, as well as the medical, and how we need to be able to integrate that in a way that's navigable for the mom, and we have to address her problems as well, because if she herself has behavioral health problems or is challenges in her household, we need to be able to identify those and give her the support that she needs to be able to provide adequate care and opportunities for a child. And so it's really taking a comprehensive look at both at the family as a whole, and what can we do to support them broadly through, and looking at social determinants as well as just the medical, behavioral health pieces, but much more broadly than that, and educational. And how can we make it easier for the family to access this?
I think if I go back to my original position about beginning with healthy children, healthy birth to 3-year-olds and healthy moms before that. Most people don't know, or a lot of people maybe do, that Georgia is a state that allows presumptive Medicaid eligibility for pregnant women. So we don't ask a whole lot of questions. We ask for a statement of income, and then the pregnant mom becomes eligible for Medicaid. We do that for a reason. It's one of the few groups that federally you can use a presumptive eligibility for. And so we've done that for many, many years because it starts with a healthy mom, and then it moves to a healthy baby. And then if we begin to coordinate resources really well so that it doesn't matter where that child presents, at a public health center, public health clinic, at a primary pediatrician in Rockdale County, wherever that is, that we have the same set of standards that we use to screen children, that we use to treat children. I think that'll be really helpful.
If I could add to that a couple things. I would say understanding the barriers and potential solutions to barriers as it relates to data. So just thinking from a school-based mental health perspective. FERPA or HIPAA and what can be done from a shared data perspective. Because I mean, we have contracted with this Georgia State Center of Excellence so that we can have rich data, but there's also data internal to the agency, and all of our partners have data. And sometimes we can share that data, and sometimes we can, or unless there's a pretty extensive MOU. So from a systems perspective, I think that's an opportunity.
I second that. Absolutely.
So the only thing I would add there is in a system of care, we're often really focused on children and families, which we should be. One of the things as we think about 0 to 3 that we need to focus on is the professionals that deal with very young children. Oftentimes, we need to make sure that the people that are working with the children are really trained to work with. It's very different to work with an infant or toddler with a mental health issue, as opposed to a middle schooler or even an older, an 8-year-old. And thinking about who are the professionals touching the children, and do they have that training and that mindset to work with a 2-generation support. So it's got to be a child and family together. And then it's got to be therapy that's really evidence-based for very young children. Recognizing that it's going to take the system of care to train people here in the state, because we don't have a lot of professionals that are able to offer those services right now.
Microphone.
Representative Dickey has reminded me of some prior work that was done in relation to home visiting through what used to exist, Prevent Child Abuse Georgia. It was a very successful home visiting prevention program. We know that Families First is changing the income stream. How soon can we on the budget committee look for new federal monies or new budget proposals that'll redirect monies to prevention programs that may include something like home visiting? What's the timetable for that money coming down?
So I think Mary and I can tag team this, and she'll probably continue to look at me, and yeah. The goal for the beginning stages of implementation is October of 2020. So that's our kind of artificially set implementation date. There is a lot of work going on right now because we know that this is not a flip the switch effort. So we have steering committees and committees, subgroup committees. We have brought in national experts. Melissa Carter from the Barton Center is co-chairing our Family First implementation group. If for those who don't know Melissa, I'd be shocked because she seems everywhere. But she's also brilliant when it comes to strategy and implementation of this work. So October of 2020 is the goal. I will say it still won't be a flipping of the switch when it comes to October 2020. One of the biggest challenges that we're running into is our technology system and the design modifications and upgrades needed in order to capture what is going to be a very subjective standard in order to pull down all of the prevention for $40. Right now, we pull down about $200 million from the feds on our foster care roles, and that is a very objective standard. If we have the right family dynamic, the right language in court orders, and the right kind of timelines, we achieve that standard, and as a result, we pull down about 40%-ish of every dollar comes from the feds in order to support our foster care program. The standard or achieving the standard for prevention services is not a checkbox or not a objective standard. It is the identification of a candidate for foster care and whether or not this individual and family meets that candidacy, and then from there, are the services that are being provided to the family in line with the services that are allowed by the feds? So to directly answer your question, I'm not sure if I have a specific date, but you will not see any pull down of prevention funds earlier than October of 2020.
May I follow up, Madam Chair? That's FY21 budget, which
That's
we
correct.
will be getting in January.
That's correct.
So that seems like maybe, perhaps, hopefully, an early opportunity for our budget document to look at prevention services that may have an opportunity to focus on very young children. And that brings me to the question I still don't understand is, what do we have to do with our Medicaid waivers to redirect more billable services to very young children? What's the process there?
If you're specifically referencing the current 1915C Medicaid waiver programs, we operate two for people, be they children or adults with intellectual and developmental disabilities. One in particular that's for the aging and it's for the older adult and disabled population. And then the fourth is for adults between the ages of 21 and 64 at admission who have significant physical disabilities. Now that waiver at its beginning was carved out to be for adults, primarily for adults who had significant spinal cord injuries, traumatic brain injury, that sort of thing. The other waiver programs, for example, believe it or not, the elderly and disabled waiver program doesn't have a minimum age limit. And so we do have some young children who are served on that particular waiver program, if you're referring to the 1915Cs.
I'm referring to how do we get more services paid for by Medicaid for children under 7? That's what I want. And I don't know how to accomplish that.
And in particular, are we talking about behavioral health services or all kinds of services?
Behavioral health services, emotional supportive services that I understand are not being paid by Medicaid now. Am I right or wrong?
The behavioral health program, as it is written now in the state plan, begins at age 4. And so it would require specifically some identified services that were evidence-based and would be added in terms of even procedure codes in the Medicaid state plan. So we would rely on DBHDD to identify what those services might be, Because again, we're not experts at Medicaid. We're not experts in children's behavioral health. So we would rely on them to give us descriptions, procedure codes, and then the same process that I mentioned before would just be added to the state plan after a physical impact.
Are y'all working on developing procedure codes and diagnostic billing things to give to them that would result in an opportunity to expand Medicaid payment for young children for emotional health?
I am not the best person to answer that question. If there's a future opportunity, I would like to invite a colleague, Wendy White-Tygreen, who is the director of the Office of Medicaid Coordination and Health System Innovation for DBHED. She is the official liaison between our agency and DCH. She would be the best informed person to talk about that work and what opportunities may be in any ongoing conversations.
So we noted that this is a big question that we really do need answered. If anyone has any more to add to that, this is important to get us where we're all trying to go. We'll reach out and see if we can do that. Thank you, Dante.
I have an adjunct to that. And
Great.
one of the things that I talked to Commissioner Berry about is getting a carve out for Babies Can't Wait. And I didn't want to say this to you, I want to blindside you because you may not, he may not have told you that we've been talking about this and we're going to be able to have children better access Babies Can't Wait, because it's not happening necessarily through the plans. And so we're hoping that we can get together and figure out a way to do this that will be efficient and also not break the bank. Because we believe that these services, these 0 to 3 services that Babies Can't Wait, are really a great benefit to the population that we serve.
My question is directed to Mr. Hemming? Impling.
Very German name.
Impling.
Yes.
You talked about OFI, what is that?
Our Office of Financial Independence, so that includes our Medicaid application and processing, our SNAP benefits, and then our TANF benefits.
So you said they're the fewest since 2005. What
Yes, ma'am.
precipitated that?
And I can't speak on what precipitated it, but right now, it's my understanding we have about, I think our actual case management roles over there, about 1,700 case managers that work very hard at what they do. But in my conversations with our OFI Deputy Division Director, he reports that that's the lowest since 2005.
Okay, so what can we do to maybe, is there anything that we can do as a body to help?
Yeah, absolutely. Yes.
I'm just asking the question.
Yeah, absolutely. I think the part of those positions is funded through pull downs from the federal government. Yep. So for any portion of the work that an OFI employee does for Medicaid, we get a pull down from the feds there. It's the exact same actually with our SNAP benefits. We get a pull down from the feds for the work. So in reality, the amount of state dollars, I can't give you, I don't want to tell you one way or another, but it is not 100% of an individual's salary is state dollars. It's a percentage of that. I don't know off the top of my head what that percentage is. I'm happy to give you and follow up as far as what that percentage is, but helping to boost those roles within our OFI would greatly assist with the timely processing of TANF, Medicaid, SNAP benefits, so that those individuals that are eligible for those benefits get them as soon as possible.
To be exact, the federal match for administrative oversight of Medicaid-related programs is 50%. So it's 50% federal, 50% state funds. And that is, that applies specifically if it's not a clinical role. If it's a clinical role, then the federal match is higher. But the state match for DFACs for eligibility is 50%.
Do you have anything else, or
Madam Chair.
you can ask away?
Okay, thank you. I wanted to go back to Ms. Adams and the question I had asked earlier about the acronyms, BBBs. And I wanted to know if there's any way we can change that, or do you see something that we can do? Because I know that there was some legislation that we passed some years ago when we changed the word retarded to mentally challenged or something to that effect. I'm not quite sure. So I'm just wanting to know, even though I know you said it's a federal, but what can we do as a state to make those changes so that we can identify children in the better?
So, actually, it's not a label that's applied to children, it's a trend in the data. So when you look at the data for suspensions and disenrollments for children 0 to age 5, or if you're looking at disproportionality data or special education preschool data, what you see is a high number of disparity. And what you see is you see a lot of children of minority, which would be the B, children and males represented in that. So one of the things, one of the problems is that children are over-identified for these services and disparately when they get older. So early intervention, looking at supporting children 0 to 3 would mean that you would cut down on that disparity as the children get older. Because it may not be that the children need to have special education services, they're just overly represented. So no children are really identified with that. It's really a trend in the data is what you see. Is that helpful?
That's helpful. I think I'm gonna come up with an acronym for you.
All right.
Okay, that'll be good.
Sounds
That's something
good.
I'm gonna work on,
Absolutely.
that we can have.
That
as
can
a-
better
that-
communicate it,
Yes,
right.
that'll be trending in the state of Georgia.
All right, let's trend it. Well, you can put it with a hashtag and it'll go viral out there, so.
Thank you.
Okay, anyone else at this moment? Okay, let's see, let me look back over here just a minute and see. So, we've heard some kind of big ideas, some broad brush strokes. Can you go in very specifically to exactly what you see that you can do? Don't worry about your neighbor sitting next to you. I know y'all interact very well and are very intertwined. We talk about collaboration, so it's kind of strange for me to ask you to go back to your silo. Go back to your silo. And what does your agency need in order from us to better support young children, their families, and their social, emotional well-being? Dream big.
So I'll take an easy one for us as an agency. Our agency's been really focused on supporting our workforce of early childhood teachers and directors in schools and early learning to address the promotion and prevention of social emotional problems. One of the things that we see, regardless of how it is paid for, whether or not it can be billed with Medicaid or if it can be private billed, one of the things we see is the real need to have a pathway for additional people to serve very young children and child family therapy, and a credentialing pathway for people with that. There are a couple of evidence-based training curriculums that could be used that other states have done, and we can, we're happy to share that. But regardless of how the services are going to be paid for, we need people that can support children at that very top of the pyramid that really need child-family therapy.
So I would echo workforce development initiatives. I've often say that our programs, if they grow quickly, that growth has to be similarly paced with trained and quality staff. Both the focus on existing providers within the state, but also our students that are aspiring professionals and providers. The second thing that I would add, there are, I think, tools already in the toolbox that I would ask maybe the committee to review. So in my presentation earlier, I talked about system of care over 20, close to 30 years now. And some things that have been incorporated in Georgia Code. And so one of those at the local level, it is, I think the driver, in the early 90s was related to children that were in crisis, but not necessarily waiting till they are in crisis. Some of the various staff around the state that we've heard about today, each of the agencies has these coordinator type, they're called different things, but just talking through at state level meetings and some of the intentional meetings, I think there are better opportunities for those staff to be connected and connected to a tool that's already available to us, which are local interagency planning teams, and maybe shifting the focus away from meeting when there's a crisis, but it's just meeting on a regular schedule just to plan for preventative services, to collaborate on these big plans. Each of us has a driver, whether it's Families First or the Child Abuse Prevention Plan or APEX. We each have certain drivers, either through state strategic plans or federal funding sources, to kind of talk on a regular basis and coordinate around those efforts.
I'm going to ignore your request to think in a silo, because public health can't think in a silo, because I think we think in partnerships. And I think what you can do for us is to set the expectation that we not only work together, everybody sitting here, but also work with providers in the community in a much more effective way. Because that's the way this is going to, that's the way we're going to have an impact. I think you can build up individual programs, but if we actually aren't working together effectively, and if we aren't actually reaching in an effective way as partners to community providers, whether it's behavioral or medical providers, we're not going to achieve what we are capable of achieving in Georgia, but we're not there yet.
I'm gonna ignore it too and say capacity within some of the existing programs, because we touch families at many different points, and along the way, we are gonna make referrals to Children First, which is gonna get them to Babies Can't Wait, and to home visitation programs. Those are some of our most effective tools, as well as education. So we make sure that children we come in contact with, especially those that have to be removed from the home at a young age, are in pre-K or Head Start or early Head Start. And so making sure that all those programs have capacity to serve families would be tremendously beneficial to us.
And I would focus, and I think this is particularly helpful when considering the legislator, and I'll turn the microphone on so I talk loud anyways, is the identification of the need. Because of our legislators represent every single citizen throughout the state of Georgia, you all have a great ability to reach out to your constituencies and find out what in the world the need is out there. And that can then be disseminated back to the agencies who need to step up to meet that need. So utilizing your all's reach as much as possible to then identify that need and then disseminate that information back to us, number one. And then Chairwoman Dempsey, the work that you did last year on sharing of data. Everybody has a lot of data here. And between at least DFAC's world, Gateway and Shines, the amount of data that DFAC's has on what would be hundreds of thousands of families is extensive. And then we think about our partnerships with DJJ, Department of Public Health, DVHDD, DCH, the amount of data that is out there, because again, that gets to prevention. Again, if somebody pops up on any of our radar, the sharing and utilization of that data will help inform the system as a whole. The challenge in considering data, and Chairwoman Dempsey, you know the challenge when it comes to data, because we've had these conversations, is often all of our data is governed by federal law.
He's talking to me, you know.
No, I'm talking, yeah, I'm talking to everyone. So when we think about Medicaid data, if we have a boatload of Medicaid data out there, the feds say the sole ability to use Medicaid data is for the effectuation and furtherance of the Medicaid program. So if we are not utilizing the Medicaid data to process and give people Medicaid, the feds may come back to us with a substantial and strongly worded letter and say, you're using this all wrong, and then they have the ability to say, we're cutting off your Medicaid funds because you're not using these funds or all of this data properly. So I wish it was as simple as being able to pass a piece of legislation at the state level that said you shall share any and all data amongst the executive agencies that you're able to. The challenge is then being able to then navigate the constraints and restrictions placed upon our agencies when it comes to the feds. So I think, again, your all's ability to have those discussions with your counterparts at the federal level and say, if you all want to get serious about agency cross-collaboration, coordination, prevention, and intentionality, we have to figure out a way to work within the constraints of data, but the restrictions of HIPAA, FERPA, confidentiality, they scare me. So largely because there are some significant penalties as a result of violations of each of those individual areas.
I would have to echo the fact that I can't think in a vacuum or in a silo. What Medicaid and DCH, in terms of Medicaid, what our value is that Medicaid is a highly technical program. There are many, many federal regulations. The list of do's and don'ts and what you can do and what you can't do and what you have to produce are a mile long. It's our job to know what they are, and it's our job also to understand, identify needs that are unmet, and figure out ways that if you can't meet all the way, you can meet part way. Just this morning, we had a technical assistance call with CMS to find out what might be some avenues for doing something collaboratively with another state agency that hadn't been tried before in Georgia. And we have federal partnerships that are that helpful with us. They certainly won't tell us exactly how to do it, but the end of the call ended, if you'll send us a proposal in draft, You don't have to really submit it. We'll edit it and send it back to you. And so our job is to get information from all of the folks sitting up here in this row, and it's information about unmet needs. And then our role is to go back to the Centers for Medicare and Medicaid Services and say, this is an unmet need in Georgia. Can you help us figure out a way to do this? And that's our role. But it relies on education, and it relies on some ability for our partner agencies in state government to say, we know that there are limitations, but we'd like for you to try, and we'll sit with you while you try. We'll sit with you through it.
Excellent, thank you for not going back to the silo. I was testing you. I'm glad to know that you each all understand the virtue of coordination and collaboration. So thank you. Anyone else have any questions right now? Nothing. Okay. That's because y'all have informed us well to a large degree. I really do think. Okay, so we're going to be looking from this committee to come up with a report that profoundly affects the work that you're trying to do. Committed to that, actually. So, some things could be short, some things could be more immediate than others to reach with. I always believe that some steps toward success encourage those larger giant leaps toward maybe big success one day. So, among yourselves, with us, can you tell us some things that you see that are, and they may be financial, they may not be financial. What are some steps we could take to try to help meet, first of all, something small, and then maybe something larger? For true success.
Public health can share its data with DFACS.
Probably puts you on the spot.
No, this is an ongoing dialogue that we've been having over the last couple weeks, and I think it's something that we may or may not be able to work out without legislation because of the federal and other constraints and the legislative, current legislative constraints, but we'll be letting you know about that after we hammer that out.
But I think to Commissioner Toomey's point is either a recommendation, a strong directive from the legislator, or just further support that our state agencies need to be having regular, intentional conversations about their programs and how those programs align and further support each other's missions and scope of our work. Because admittedly, we're just not good at that. We get siloed. And it is I've got my 5 or 10 fires that I'm putting out today, and we are excellent firefighters, but when it comes to some of the more kind of global dream big work, often it doesn't happen as frequently as it should, because we're thinking about how can we make sure our 13,000 children are safe, or we're implementing programs and providing the needed public health and services to the family. So one is agencies having intentional, regular, collaborative conversations about the work that you are doing and how we can further bring together those agencies and cross-collaborate is, I think, step one. Because again, as we said earlier, I don't think there's any reason to create new when there may already be something there, we just don't know about it. But then the other elements, and I sound like a broken record, is making sure that we know the needs that are out there, so that way, whatever those needs are, we're able to cater our work and our services towards those needs. I'm not exactly sure how to do that. I mean, I could pull you zip codes from where our most abuse and neglect reports come from. I can, honestly, we can get that down to a neighborhood. But then utilizing that information to identify what's happening in that neighborhood and how we can get everybody together to serve that neighborhood the best possible. I think that is, I mean, that's a great system. Instead of reacting in that neighborhood all the time.
That is a great system, and that's a big idea you just gave us, so thank you. But it is a very doable idea, because like you say, the data does exist right now, whether you're talking about the drug influences there, we can go right to that issue. Single mothers, fathers taking care of children, grandparents taking, there are ways to get to that. So I think I'm hearing one sort of maybe immediate step we could do to try to figure out how to target certain populations in a very careful and caring way, not in a revealing way, not to say, hey, your neighborhood's the bad place and that's where we're going, but to interject very carefully the workforce that's necessary to be there, the friend and capacity building that could exist right there to help one spot get better, to help another spot. So y'all think about that. Let's all think about that. See how we can come together and do it. I know there's a lot of it going on, because there is. The interagency conversations that are going on are really good. And probably most legislators don't know it, really don't know how hard y'all do work behind the scenes to try to tackle the problem. But if there's some ways, whether that becomes like, okay, we've got to figure out how to work with that de-identified data, that we can do, that there are ways to do it, and target some specific needs. I think that's a good idea. Any other ideas?
I haven't been turning it on, so let your voice be heard by turning it on.
So one thing personally that I've started to look at that already exists within my agency, but also in some of the partner agencies here, is, and I would encourage the committee to also look at it, are where current positions are shared between agencies. So earlier I mentioned Wendy Tygren, who is a liaison between UVHDD and DCH. I am aware of other places in the system. Speaking with Dr. Gary McGivney here recently, I understand that there's a shared role between DCAL and DOE. I think that encourages more collaboration and having individuals that understand the different agency cultures and how things move either quickly or slowly or just, the right speed. And there's sometimes differences between agencies. The other thing I would point to, the System of Care State Plan. In my presentation, I mentioned that the last time we developed that plan, we missed an opportunity to focus on young children. In the way that seems to come together, meaning you develop the plan, there are strategies, and then there are things that require funding. And so some of that funding is already available within state agencies, but having a plan allows the particular agencies to repurpose or direct those funds to support those particular goals. In other instances, there are funds that must be identified to support that work. And so the way that transpired the last time around is the System of Care State Plan was created, and there were several strategies and action items, and then which developed was the Children's Commission for Behavioral Health. And a number of the things that were identified in the plan were recommend and eventually funding for those things that didn't have funding available, or enhanced funding was made available to support those things. And so I guess that's a long way of saying there are opportunities to look at existing funding and opportunities to align, but also particular plans may also provide a roadmap to the committee for where there are gaps within the system and opportunities to connect the dots.
So we do have a shared position between our department and the Department of Education that's actually focused on promoting positive climate and improving interactions around PBIS that was funded. And they really focus on actually pushing up the practices from preschool into your early elementary classrooms to improve classroom climate. And that's a position that we were funded. We pay part through federal funds and then part through the state funding that's going to DOE for PBIS. One of the things that for a lot of up here may be common, a lot of people here in this arena are trained on trauma-informed care. However, as you get out of kind of this arena and move more into other stakeholders, whether they be community members, teachers, school system folks, understanding the impact that trauma has on young children and their families, and actually how it affects development and brain architecture, and really should change how you interact with children and families to get the outcomes you need. It's really impactful in people changing their framework and can help mitigate some of the issues that are going on with very young children and how you interact with them and their families. Our agency has a small community pilot where we're through a preschool development grant, training 6 communities across the state in trauma-informed care through the Child Care Training Collaborative at Georgia State, and then having those communities look at developing trauma-informed plans in a local community. So I think, we often think people know that, but unless you're in child welfare or maybe you're in early intervention, you may not really understand the impact of that. So using trauma-informed care training as an opportunity to help people shift their framework is kind of a short win too.
Specifically focusing on family first, one of the areas that we're finding difficult is making sure that, and this goes to trauma-informed care and impact, is that we have enough providers to be able to give the services in the communities that need them. So it comes down to capacity and making sure that whatever need is there, there's actually a capacity there to serve that need. And so when Family First requires that the providers that are giving these preventative services meet various federal requirements, that their practice is well supported, that it's a trauma focused service, and the other 2 different areas are escaping me at the current moment. But what we're finding in our pilot program or in our work with providers is that there are areas within the state where there's just not a capacity to give the services to the families that need them. So I think that's another area that the work of this committee and identifying gaps in services or gaps in providers and how the state could help support the further development of providers in those areas to make sure that families and parents of children that need these services can actually get the services. One of the areas in Family First is an accreditation and the substantial cost of accreditation That's not a check that we're able to write from the division, but thinking about seed money for people to either be able to get accredited, for providers to make sure that their staff and employees have the right training, knowledge, resources to be able to give these services to the families and children, I think is another area that could be of particular interest to the committee as well.
I'm just reflecting on what Chris just said. You know, there are 130,000 babies born in Georgia every year. Only a small, I hope only a small portion of those infants and children come into your services. If public health had the opportunity to actually fully, what's the word I'm looking for? Fully engage with all the communities in 100% capacity, we would put DFACS out of business because all those families would be served, all those children would be identified early, all of them would be channeled into appropriate services early before problems occurred. So my big dream is to have a system that actually is a truly preventive system that's robust enough to put Chris out of a job that he could work.
And my dream is for you to put me out of business. Absolutely.
I mean, so that's the real opportunity. I mean, these same communities, if you look at zip codes, these are the communities where there's congenital syphilis. These are the communities where there are congenital HIV, completely preventable complications that shouldn't be happening in Georgia in 2009. I mean, we can be doing better as we think about, we dream about how to make the system robust.
And I'll just echo the workforce development as such a critical need. They're part of the work in the CMOs, the care management organizations, is to geomap their provider network to assure that there's network adequacy. And in some areas of the state, it's just tough. In many areas of the state, in particular specialties, it's tough. And so I think all of us here have talked about workforce development as being such a primary need.
All right. Any other questions from the panel or thoughts that anyone would like to share? Yeah, go ahead.
We talked a lot about cross-agency collaboration. I know that's an issue, but could y'all give us some examples of collaborating with community nonprofits or faith-based organizations? I know the church that I serve, we collaborate a lot with our DFACs in our area, and our goal is that when they have a need, they call us first. I feel like there's an army of people out there with all these nonprofits that could really come alongside and be a very affordable way, to address it, because, obviously money's an issue. It's limited, and it may be more limited next year than it is this year, so we can't money can't be the answer, and it's people. And so how do we get more people involved in this process? So I don't know, can any of you speak to that? Is that going on? I'd love to hear some examples of that.
Well, we've done a lot of that in the foster care system with the faith community and found it's been tremendously successful. And I think one of the things that, kind of reflecting upon that, because it started probably 5 or 6 years ago in the state of Georgia, is we realized that the general public didn't know there was a need. And so there was a lot of work done to educate them and to engage the faith community in opportunities to serve families that may not be becoming a foster parent. That's the other thing that we had never provided an opportunity for, is how can you serve without, taking that deep commitment of being a foster parent, right? And so, care teams supporting foster parents have certainly been an incredible vehicle. We've seen a lot of retention with our foster parents as a result of it, and an increased number of foster parents as well. Some of those people that serve on care teams then go on to become foster parents, which is wonderful. And some of those organizations are beginning to look at how could they serve some of the birth parents? What could that look like? And kind of developing that model, and I think the potential there is really huge. That's some work I'm really excited about. Of course, partnership parenting is something that we promote a lot with our foster parents, to how can they walk alongside the birth parent with their journey. We've done a lot of storytelling. They're really, I should say, beginning the process of that. So that people understand some of the remarkable change that we've seen some parents make and the challenges that they've overcome. I think it changes the conversation completely when you tell those stories and give people ways to get involved.
How do we hear those stories?
Well, we started, so we have a couple of complications. One of them being the person sitting next to me, who's our lawyer, with families who may not, right. But we are working with families who, and really being intentional about engaging people after they've completed services with us. Would you be willing to tell your story? And we've started capturing some of that on video, inviting people to come speak at groups, really looking at any way that we can do that. We celebrated National Reunification Month for the first time in June, and each of our regions had celebrations, and those were public events largely, so we're really trying to kind of change the conversation around that. Mm-hmm.
So I have a number of examples that I can share. So I can speak to my office, but then there are other offices I know enough to be dangerous about, so one of the philosophies within the agency, so we are a recovery-focused organization. At every public meeting, we start with a recovery story of lived experience. Within my office, we've created a certification process, well, really all the offices, the latest one being parent or youth certified peer support. It's a 40-hour certification. It's a new practitioner type, if you will. Individuals get the certification to have a continuing ed, and we utilize them at all places within our service array. The motto is nothing about us without us. And so, that gets to system care values of being family focused and elevating youth and family voice. On an event level, for 13 years, next year, we'll see what the budget looks like per se, but for 13 years, we've hosted what we call System of Care Academy. We bring all the child serving agencies and nonprofits, individual practitioners together for a day of learning. For practitioners, a great way for their continued ed. We offer ethics every year. There's always a youth track to that, young adult track. Within my particular office, we have cultivated relationships with nonprofit organizations, whether it's NAMI or Voices for Georgia Children, more recently GEARS, shifting and understanding that we missed that opportunity with the last System of Care State Plan, so we're happy about that new budding partnership. We have an office within my division called the Office of Recovery Transformation that recently embarked around a faith-based listening tour. Part of the work with behavioral health is destigmatization, and I guess breaking down some of those barriers to promote the willingness to seek services and pursue wellness, and tapping into the faith community. There's still a lot of that within the faith community as it relates to acknowledging and working towards supporting the individuals that they serve. But there are a number of collaborative opportunities. There's nothing that we can do alone, which I think is why all of us kind of, when we started to respond to the silo question, we couldn't, because it takes a village to do this work.
Sure. Thank you.
and I know you're from Woodstock, and you have one of the best health directors up there, working on issues, and, you know, there are programs at the local level where, like resource mothers, community health workers, that men and women from the community who actually are providing support and education in the community to others, as well as looking at faith-based opportunities to reach hard-to-reach individuals. And so you look across the programs, whether it's maternal and child health or chronic disease prevention or HIV. Actually, in your area, they have collaborations with local OBGYNs that see women for free, and which is really an important area where I would like to model some of these activities. So I think there's the real power is at the local level where these collaborations can occur, and I just get a gleam in my eye. I can't take credit for them. I just say, go forth, do good. I'm gonna do everything I can to help you, and learn from it and share with the other districts so they can do that as well. Sure. I didn't turn it on again.
Yes, you did. So I missed one particular organization, and so Georgia Parent Support Network is a partner to the department for many, many years. They wear a couple different hats, so they're a nonprofit, family-driven organization, but they also are the umbrella organization for Youth Move. So the Georgia affiliate for Youth Move, which is a national youth-driven organization, as well as the Federation of Families for Children's Behavioral Health. So they're the umbrella organization in Georgia for that. And Georgia boasts the national or the largest federation of chapters in the country. And so that work or this partnership was born out of that system of care work many, many years ago. And so they've continued to grow. We work with them in varied ways, so whether it's with peer support, whether it's with educating communities. They release weekly something called Did You Know, where things that families should know, whether it's to access services or about study committee work like this, or just breaking it down in layman's terms to try to reach out into communities.
One thing I would just add is our agency has worked with local communities to really support them in developing what we call birth to 18, so birth to age 8. It's been an initiative through Get Georgia Reading, and what it does is whoever is in your local community, and who are your foundation partners, who are your faith-based partners, who are your community agency people. How do you come together and then think about for your community, your families, your kids, kind of looking at your early childhood continuum. You got to get kids to age 8. If you get them to age 8, you get kids and families to age 8 being successful, then a lot of research will show that you have kids that are graduating from high school and kids that are successful adults. But then you also, from another perspective, use that as a leverage to certain things, like the very large L4 GA grants that Department of Ed just got around literacy. One of the requirements there to be eligible to apply was that you had to have a system and a community team that looked at birth to 8 partners. When we look at funding things at a community level, then you have to show us what that birth to 8 team is. That includes mental health, that includes your DFACs, partners at the table, and it's kind of a door opener for other funds that we might release. So you have to show what that active commitment is. Now what you're doing at a local level might be different because you have different people and you have different needs for your local community, but it's been a way to support local communities. Get Georgia Reading has done a large amount of training with local communities to how to form those kinds of teams. We've done it through our Early Learning Challenge grant. But then the key, kind of the secret recipe is how do you then use that for leverage to say, Okay, so you want to apply for a community grant, or you want to apply for these things, you want to apply for this literacy grant that goes through your local school system, then show me how you have this active team, because then it broadens the thinking. You know, you have school superintendents thinking about partnering with childcare. They're thinking about what is important going on in 0 to 3 because those kids are coming to them. And so that's been a really effective kind of leverage for us.
Wow. I want to say thank y'all. Thank you for your intentionality, for the work that you've just exposed. And I know this conversation is just kind of the tip of the iceberg, because I can see all of you right now. I really can. I can see you think, oh, I could have said this. I can see it. It's just there. There's so much to talk about in this arena. So I want to ask you to do something. I want to ask for 2 things. The first one is, after you leave here today, if you think of more that we need to know, please don't hold back. Please send it forward to Sarah, to me, to Lori, to get it to us, please, because we're going to try to put together something that becomes a life plan for this, and that we can do it. Like you said, Dr. Stewart, we can do this. We can do this. So as we leave today, though, I want to ask y'all one quick question, and it's short. It'll be an easy sort of answer, I hope, for you. But we began this conversation, not today, but at our very first meeting, talking about the architecture of the brain. And I keep going back to that moms, parents don't know when that baby is handed to them how much opportunity they really have to have a healthy, growing, vital brain versus one that is much smaller, and they just don't know. And they really don't know how to do it. So many do not. And you don't think of it. Even very well educated people don't think, I need to talk to this baby nonstop. I need to touch it. This is that year. This is that magic moment in time. So I want to ask each of you if you could give us one thing where you thought we could find a touch point. What is the best place? I know what I think mine is, but I want to know what yours is. Where we could connect with that mother in a very powerful way to help them realize what they have is an opportunity to grow a successful person or to really create a problem.
So I'd say at the hospital.
Right.
You know, at birth and engaging that mom from day one, beginning with the hospital staff and then potentially referring to a home visitation program or whatever that mom's needs are. We've seen some success, we heard in the Gainesville area, for moms who have been using and peer supports with those engaging those parents even before mom gives birth, and then having that person who has that lived experience that can walk alongside them as they're in treatment. But so I would say at birth.
Although in the hospital, there's so much going on, and especially a new mom may be just overwhelmed. And I wonder how much can you internalize when you're hearing everything that's happening to your baby, including having your metabolic screening done and the hearing screening done, and is that really going to be where it occurs? I mean, that she can internalize this. And so I too think if we can expand to all 159 counties. We have 159 health departments, one in every county. We're the only health entity that reaches all 159 counties. If we can make this a priority for our work and our reaching out to children, continue to work with other providers like pediatricians, like family practitioners, as well as our public health team, I think that we can reinforce that. Because I only worry if we're relying on that hospital visit. My neighbor just had a baby, and I referred her to Children's First, because the baby has a cleft lip and a cleft palate, and she's just absolutely overwhelmed and doesn't know where to begin. And it reminds me of how much we expected that mom in that short time. And now we don't keep moms for 3 or 4 days anymore either. It's, you know, it's you're out the door, you know, so it's a pretty short time to get that life-saving, truly life-saving message. And so I think we have to think about every opportunity we touch that child and that mother before and after pregnancy to reinforce this.
Yeah, and I would add, Google is a scary thing, because whenever I search something, it shocks me how quickly the ads pop up of the things that I just searched. So think about the first time a pregnant mother Googles the word prenatal vitamins. I mean, you can, as scary as it is, you can buy those keywords and place your ads associated with those keywords in the geographic area that you're looking for. So anybody that searches the words prenatal vitamins in the state of Georgia, think about buying ads for our programs to help advertise, inform, educate them on the importance of brain development, trauma, services. All of those things are within our capability. They're things that Chase does with credit cards every single day. So if some of our tech companies and travel companies and things like that are doing it, there's no reason that the resources of the state of Georgia should be limited as well.
So my suggestion is not necessarily a Medicaid suggestion, because just as I mentioned before, Medicaid has very strict rules about what it can fund and what it can't fund. But I'll tell you, as an avid poster child and a MARTA writer, because I write MARTA every day, and I watch some of the most stressed parents, be they moms or dads, it doesn't matter. I watch some of the most stressed parents I have ever seen just try to make it through the day. And I think that while social determinants is a relatively new buzzword in parenting and in healthcare in general, and it only goes so far with Medicaid funding, but I do think we need to look much more holistically at what it is to be a parent and how one copes with the day-to-day life struggles now in parenthood and how you juggle the two. And so I say that as an avid MARTA writer and seeing some of the most stressed parents on the planet. And I see that also with my own daughters who are raising their children. It's just a stressful time. And I think we need to somehow figure out how to address that, how to build coping skills, how to begin with early childhood education so that we help parents have some sort of expectation for their own lifestyle and their own capacity in the workforce, et cetera, because I just think that so much of it is really stress-induced.
So you're right to focus on relationships. With young children, it's relationships, and whether that be with a peer, and having a peer, or whether it be a lot of our young parents now, their relationships are with the people that they connect to online. And there's a lot of research there about how, whether it's an ad or it's social media, they're looking for their connection, their relationships that way. And then also the other relationship you have with the very young children is where you take your child every day. Childcare is a huge opportunity in early learning environments to connect with parents and give that workforce the tools to talk about what's going on with their children, help them connect with those parents and and help educate those parents about the opportunity and the power that they have to interact with their very young children, because most of our children are in some kind of out-of-home care every day. And those are the people that you're relying on and that you have a relationship with.
So this is a difficult question. if it were kid focused, I would call upon the old adage to meet people where they are, and children are in school most of the time. But for mothers or mothers-to-be, it's a little more difficult for me. And I think social economic status would change based upon that. For one particular group, I may say like gym or yoga classes. For another particular group, daycare. If it's a younger mother, online, social media, that's already been mentioned. But I think that all can be summarized in, I think, a non-traditional format, whether it's after hours or where people have some downtime to be able to connect and have some real conversations about the importance of young children, social emotional wellness and development.
Thank y'all. You've given us a lot to think about. And I just value, and I'm sure the committee does too, I speak on behalf of all of us, just the great work that you do every day. Thank you.
Before everyone leaves, we're gonna get a picture. We're gonna get a photo.
Nice to see you, nice for what you do. Yeah,
Real quick. Great. Yes.